Well, it's good to be here with everyone today. For my journal club, I'm going to be talking about ketamine. In particular, I'm talking about a trial that took place pretty recently, and it was published last year. That trial is called the CADIS trial. The formal study is ketamine for the acute treatment of severe suicidal ideation. It is a double-blind, randomized, placebo-controlled trial. The acronym doesn't really stand for anything because it translates from French, but I like to think about this as the ketamine is safe trial or ketamine is safe question mark trial. So we can go ahead and jump into this. Let's go on to the next slide. So I have no disclosures to discuss for this topic at hand. We're just going to talk about the data and kind of go over what they found. So to start with, I want to talk about why this study matters. There's been a couple studies that have actually studied ketamine for acute treatment of mood disorders and whatnot. So there's a growing body of evidence that suggests ketamine may have a role in the management of various acute and chronic psychiatric conditions. A lot of this data is kind of mixed, but there is evidence ketamine may help with acute SI. But the studies that have done this research have used questionable methodology. In particular, when they're assessing suicidal ideation and suicide risks, they look for a 50% reduction in symptoms rather than remission, which these researchers felt was not a good enough standard to really prove anything, which is why they use different metrics for this. In addition, there has been little to no research on how other psychiatric conditions moderate the response to ketamine, and that was one of the aims of this study. This is also important because existing medications for treating suicidal ideation are slow to take effect, with those predominantly being antidepressants, clozapine, and lithium, and they are all controversial for various reasons. Antidepressants for their risk in kids, for possible tardive dysphoria, also for the risk for manic conversion and mixed states, clozapine for metabolic concerns, as well as the difficulty of monitoring, and then lithium, which I think shouldn't be as controversial, but there's a lot of disagreement on whether or not it works, and it also has some chronic effects. In addition to medication, psychotherapy is effective, but it can be difficult to access. Sometimes it's slow to work, leaving people in crisis when they really need something to work more rapidly. And then evidence is split on whether ECT helps acute SI. There are certainly some populations where it seems to benefit, but how rapid it is, how easy it is to access, there's a lot of barriers involved with this. In addition, ketamine is a non-competitive NMDA glutamate receptor antagonist. It's one of the three main glutamate receptors, and there are numerous new medications in development targeting this receptor. Ketamine's utility may help us inform which patient populations would benefit from future treatments, even if we feel like ketamine is not something we want to use particularly often. And then just kind of as an overview, even with all the advances we have made in psychiatry, suicide rates remain high during inpatient stays and for several months following discharge. So it is certainly an area that we have a lot of improvement to make. And it is certainly one of the worst outcomes we can have is when someone completes suicide that we care for. So this is an overview of what we're talking about. You all don't need to clue in too much to this little infographic here because we're going to talk about it for the entirety of the duration. But the main points that we're going to go over is first, I will break down the main claims in the summary statement here, kind of to guide our discussion and talk about what exactly we are looking for in the data. We will review the study design as well as the inclusion and exclusion criteria. We will discuss population demographics and the main metrics used for assessing suicidal ideation, as well as a couple other things. We will discuss the intervention performed. We'll discuss the outcome, the data, the results. Then we will circle back and talk about the main claims extrapolated from the summary statement. I will tell you whether or not I think they were supported and give some commentary on that. And then we can move on into a question, answer, and discussion session. So the first thing we're going to talk about here is this summary statement. It is on this little infographic. This study was published in BMJ, which is a reputable study, and it has already gotten a lot of press. So the summary statement says that the study confirmed the rapid, safe in the short term, and persistent benefits of ketamine for acute care in suicidal patients. They also comment that comorbid mental disorders appear to be important moderators. So the five main things that I extracted from this statement was number one, that ketamine is useful for or ameliorates acute suicidal ideation. The other thing that they said is that it is rapid acting. They said that ketamine is safe in the short term, and in this study, that is 6 weeks. They said that it has persistent benefits even past the acute phase of managing suicidal ideation. And then they said there are certain mental disorders that moderate the efficacy of ketamine. So next up, we're going to talk about the study design. So we're going to move on over that. So this is a randomized, double-blinded controlled trial. The study was conducted through 7 sites located in academic hospitals in metropolitan regions of France, starting in 2014. The inclusion criteria essentially were voluntary patients 18 years or older who were deemed decisional and flagged high on the clinician-rated scale for suicidal ideation. We will talk about that here in a little bit. There were several exclusion criteria, which I think is important to consider for this study. For one, it excluded anyone with a history of schizophrenia or any other DSM-4 listed psychotic disorder. It excluded schizoid and schizotypal personality, any active substance use disorder if it had been within the last month. So for patients that might be 2 or 3 months out from being clean, they would be allowed in the study, but it did not consider nicotine or caffeine. Anyone who had a urine drug screen that was positive for anything other than cannabis was excluded. No pregnant patients, no one who had unstable or questionable somatic medical conditions, any medical contraindications, particularly kidney disease or major cardiac concerns, anyone undergoing ECT, or anyone who had been enrolled in any other interventional study within the last 3 months. And here you can kind of see a little bit of overview over this. So patients were randomized. They were randomized 1-to-1 to placebo or ketamine after inclusion and before treatment preparation. They used a program that was based on the mini international neuropsychiatric interview, which is kind of able to classify people into different diagnostic categories. A lot of this is based on past psychiatric history, though it can do some diagnosing in the process. This was administered by a computer. Patients were then stratified to groups for different centers. The investigators and the patients were blinded to the study arms. Only one designated nurse had any knowledge of the randomization results and was not involved in any other arm of the study. The infusions that they used for placebo and ketamine were both transparent and visually similar to prevent detection of placebo versus treatment arm. We will talk a little bit more about that later. Essentially, you can see here some of the overview of the demographics. So you have about a 1/3 split between bipolar, major depression, and other diagnosis in both groups. And then you had a couple people withdraw after the first treatment. Then you had another treatment at 72 hours. Then there were a couple more people that were or were lost to follow-up within the next 6 months. Of note, there was 1 death in the ketamine treatment, and we will talk a lot about that later. And then the study was completed at 6 weeks. So we're going to talk a little bit more about the population, some of the demographics for the patients included in the study, which this really is one of the more important aspects of the study. So 156 adults ages 18 to 76 were enrolled in this study. The median age was 40. For suicidal ideation, the main metric that they used was the Beck scale for suicidal ideation. This here is Aaron Beck, one of the founders of cognitive behavioral therapy. This is an empirically validated metric that has been reproduced in countless languages and is really one of the best standards you can use to assess suicidal ideation from a questionnaire. It consists of 21 questions and can be self-administered within 5 to 10 minutes. The scores range from 0 to 38. Higher number denotes greater severity of suicidal ideation. At the start of the study, the mean score in both groups was 22. There's a little bit more on demographics to include. The majority of the participants were female at 70%. Again, roughly a 1/3 split between bipolar, that's 1 or 2, major depressive disorder, or general anxiety disorder, panic disorder, etc. And all those other anxiety disorders were classified as other, and we'll talk a little bit more about that later. This was a very high-risk populace. 90% of participants had a previous suicide attempt. Many of them had multiple. Again, the age groups range from 18 to 76. But very few patients in the groups actually had a history of substance abuse. It really does seem like they selected for patients that they did not think had a risk for dependence whenever they were formulating this. There are a lot of other metrics that they use that we don't need to dive too much into, but just kind of to touch on them. They talked about the Beck Hopelessness Scale, Columbia Severity Suicide Rating Scale, which we've talked about, the IDS-C30, which is an inventory for depressive symptomatology, a PPP-VAS, which is for physical and psychological pain, and then they also used a couple other metrics, which we'll talk about later. There were no major differences found between the groups. You can see all the data here. Some things that I think are important to kind of note here is that about 40% in the placebo group and the ketamine group were on antipsychotics. So even though they did exclude patients that had a primary psychotic disorder, if you had affective illness with psychotic features, some of those patients were included in the study. They did not go into too much detail about how many of those patients there were, but there were some people that were psychotic, that had psychotic depression that they felt still were decisional that were allowed in the study. So we'll move on from here. The next thing that we're going to talk about is the intervention that was performed. And this is actually something that I think we need to touch on for a minute here. So what they did in this study was they took all these metrics and they evaluated the patients as soon as they got into the study. And once they were assigned to groups, they were given an infusion, and the infusion was done over 40 minutes. And this consisted of one of two options. The treatment group got ketamine. This was done at a rate of 0.5 milligrams per kilogram. And this was in a clear bag, and you could not tell what was actually in it. The placebo group got normal saline. And this is actually something that's important to remark on. So more recent studies actually use midazolam or Versed for these studies. They found that that is a little bit more reproducible, and is also a little bit harder to tell whether or not you're getting the treatment because it has a little bit more of dissociating effect. But they were very closely monitored, and the patients had to complete a lot of scales throughout this study. And those scales were done at numerous points. The first point was at 40 minutes, which is immediately following the treatment being done. Then they were kept for observation and done 2 hours later, and then 4 hours later before they were allowed to actually go home, or if necessary, they were kept on the unit. Patients were evaluated on day 2 and 3 as well. During the entirety of this treatment, patients were monitored using the Young Mania Rating Scale, as well as the BPRS, which is the Brief Psychiatric Rating Scale. Both of these metrics are used to assess basically for mania and for psychosis. And we'll talk a little bit more about those later. Another thing that was noted for this is that 24 hours after the initial treatment, patients got a second treatment. So if you were in the ketamine arm, you got another ketamine treatment. If you were in the placebo arm, you got another placebo treatment. And then there was follow-up done on day 4, week 2, week 4, and week 6. The vast majority of patients in the study had no side effect from either treatment. So you can see a little bit of the breakdown here. The most common thing that patients experienced was sedation, with about 11% in the treatment group, 2.4% in the placebo. And then another major side effect was depersonalization or derealization, which was at almost 10%. There was more nausea in the ketamine group, as well as a lot of other side effects. One patient did report hallucinations. You had a couple patients that were hypotensive or tachycardic. One of the interesting things about ketamine is that it has a very varied response on autonomic system. Some people become tachycardic and hypertensive. Some people become bradycardic and hypotensive. This is not exactly fully understood. There are dose relations to this, but people's response to it is somewhat varied. And this is actually something that you see similarly with a lot of hallucinogenic drugs, where the actual side effects are very varied from person to person. But overall, when you're looking at any side effect experienced, 20% of patients that were in the ketamine group approximately experienced some form of side effect from the treatment, whereas 10% of patients in the placebo. So roughly double the patients had some side effect from the ketamine treatment. So some patients probably were able to detect what treatment arm they were in, especially if they experienced depersonalization. But for the most part, the majority of patients had no side effects and would not be able to clearly tell what group they were in. So the heart of the study, we're going to talk about the outcome, the data, and the results that was found from this study. So what they were looking for here was suicidal remission. And this is actually a pretty substantial or significant difference from past studies, because they wanted to know if the patients reported no suicidality, essentially, from the treatment. And so they were looking for a scale of 3 out of 38 on the Beck Suicide Scale. And these metrics, again, were done at numerous instances during the treatment. And so you can see the graph right here. And I'm going to pull it up to make it a little bigger. So you have here at T0 is when the first treatment was done. And then at about 40 minutes here, you have the first evaluation. And then at about 2 hours here, you have the second, then the 4, and then you have 1 day, and then you have 2 days, and then you have 3 days. And even though they analyzed most of the data at the 3-day mark, you can see clearly here in the data supports that even at 2 hours separate substantially from placebo, with a 40% reduction, or 40% of patients having full remission at 2 hours, whereas it's about 10% or so in the placebo group. So on day 3, if you're looking at the actual numbers, 63% of patients in the entirety had remission compared to 31% in the placebo group. They also analyzed a lot of other metrics in this study. I'm not going to go into detail about those too much because it's really, I don't think, necessary for the heart of the discussion, but they had the clinician and the patient rate their depression on different indices. they assessed psychological pain, they assessed hopelessness, and they assessed global clinical impression. In all of those aspects, the patients that were treated with ketamine had an improvement. However, there was no difference found in physical pain between either group, suggesting, as a growing body of research has done already, that ketamine is likely not effective for the treatment of chronic pain, and there's questions about its efficacy for acute pain, but that's another talk. But one of the big things that was really significant, and this actually stands out prominently from other studies, is that there was a big difference between the groups. And they, as I said, had about 1/3 of the patients were diagnosed with bipolar disorder. And so that if you look at the results here, 84.6%, roughly 4/5 of the patients that had bipolar disorder had complete remission. And this is actually very substantial when you compare it to unipolar depression, where there is really no difference. I mean, it barely even had any visible separation from placebo, and there's no statistical significance for this factor, which does suggest that major depressive patients did not respond to ketamine at all. Then there was a subset of population that almost responded, and probably there likely are subsets within this group that would respond if it was more clearly teased out. And so for this group, you had 61.9% compared to 30.8%. Talking about that other group, because the authors did go into a little bit of detail, this included people with PTSD, persistent chronic dysthymia, generalized anxiety disorder, as well as panic disorder, agoraphobia, and then it also was likely to include patients that had personality disorders. When you read the study a little bit more fully, they actually say that they think a lot of the patients in the other group were people that had personality disorders, some of them likely having borderline personality disorder. And so there's a good chance that there is some efficacy for some subset of people that have personality pathology, at least for suicidal ideation. However, at 6 weeks, the results were more nuanced, and I think probably a bigger thing to kind of look at and evaluate as we move forward, because I disagree with some of the assessments that were made by the actual people that ran the study. So from onset to finish, there was a persistent distinction between the ketamine group that's denoted in purple here, as well as the placebo. I mean, at least visibly you can tell. And so if you look here, you have the treatment at T0, and here is at about day 3, and then you go on here for weeks. And as you can see, there is a slight improvement at the beginning, and then ketamine kind of has a little bit of a rebound, but it still stays persistently elevated. However, with time and simply just allowing things to work out, the placebo group did improve and return to baseline anyways. So whenever you're looking at this, they actually break down the metrics. So about 70% of patients that were treated with ketamine had a remission at 6 weeks, whereas about 56% of patients did in the placebo group. So there is a numerical difference, but when you do a statistical analysis, this actually doesn't separate. Even so, we will talk about it later, the researchers did say that there was a persistent benefit noted for ketamine. And this is a sizable and appreciable difference, and it's something to remark on. You know, there were 3 previous studies, as well as the meta-analysis, looking to see if there was a persistent benefit for suicidal ideation. And those studies were using a less rigorous scale of a 50% reduction in symptoms, and they found no long-term benefit regarding ketamine. And there's a lot of reasons that might be. One possible explanation for it is that this was a more broad populace, and in particular included patients that had bipolar disorder, but there also is a question of power. Even that meta-analysis includes only about 60 patients compared to this study, which is much larger, including 156. The authors do speculate that with a larger study and more power, you likely would find statistical significance, and that is something that they can look into in the future. Now, no mania or mood switching was observed in any patient during the study per the YMRS and the BPRS evaluations. And so I kind of included these here for people that aren't familiar with it. So the Young Mania Rating Scale is used to kind of evaluate for mood switching, and in particular for people having manic conversion from depression. And this is something that you have to be mindful of, at least in ECT, which is sometimes a comparison for ketamine. So it looks at things such as elevated mood, increases in motor activity, sexual interest, changes in sleep, irritability, speech, language, disorganization, and then thought content, aggression, general appearance, and self-care, as well as insight. And so again, they found no difference in either group at any point through the YMRS scale. Now, of note, though, there are several patients that dropped out and were lost to follow-up. in several patients that attempted suicide, and I don't think that they were able to fully evaluate all the patients to know truly whether or not there was any manic symptoms. But at least all the patients they had data on, there was nothing to suggest anyone became manic from the treatments. In addition, they wanted to monitor for psychosis to see if any psychosis was worsened by ketamine. This is definitely something that we have to be mindful of and be concerned. And so they use the brief psychiatric rating scale, which is also sometimes used to kind of diagnose or evaluate for schizophrenia. And so this looks at things like somatic concern, anxiety, withdrawal or negativism, disorganization, guilt, perseveration, tension, and then you have mannerisms, posturing, a couple other mood symptoms, hostility, suspiciousness and paranoia, hallucinations, psychomotor retardation, and catatonia, cooperatability, bizarre thought content, and then you have blunting of affect, excitement, and disorientation. So again, they did not find any distinction between any of the patients in regards to these aspects. No one became manic or psychotic per their evaluation. And so that is something interesting to note because there hasn't been too much research on bipolar patients with ketamine, at least in these intravenous treatments. So, of note, from day 4 to the end at week 6, 6 patients in the ketamine group and 8 patients in placebo group attempted suicide. There also is a note that 1 patient from day 1 to day 3 attempted suicide in the ketamine group. However, of note, no patients in the ketamine group who were diagnosed with bipolar disorder attempted suicide, whereas 2 patients did in the placebo. However, 1 patient in the ketamine group did complete suicide, and this was reviewed by an independent committee, and it was briefly commented by the researchers, so I did not go into detail with it as much as I think they probably should have. They did not formally tell us what diagnosis the patient had, just that no bipolar patients attempted suicide or completed. So what was their reasoning behind this? So there were 3 main things that they said, and this is why they said they did not think the suicide was related to ketamine. Number 1, this patient and none of the patients had any worsening of depression or suicidal ideation scores after the infusion. In other words, they say that because the patient's scores didn't get worse, that they infer that there was no delayed effect. I think that this is questionable, and we'll talk about this more later. But at least what they're saying is that the patients didn't seem to become more depressed from the ketamine, so there's no reason to suspect that dysphoria led to them attempting. Of note, all these patients that attempted suicide were poor responders to ketamine during the first 3 days, as indicated by their scores on these metrics, suggesting that the people that attempted suicide were patients that were not ketamine responders. And then, although they do say that just by time alone, some of the patients did achieve remission of suicidal ideation, likely just as the placebo group would, which they think led to decreased vigilance and is partially the reason you had the attempts and maybe why you had the completed suicide. So we're going to kind of go over the claims that they made originally with the study, and we're going to talk about what all I think regarding these things. So again, these are the main claims that I extrapolated from the study summary and what I think were the main discussion for this actual incident. So number 1, ketamine is useful for ameliorating suicide. 2, that it's rapid acting. 3, that it's safe in the short term. 4, it has persistent benefits. And 5, that other mental disorders moderate the efficacy of ketamine. So the first thing we're going to talk about is this claim that ketamine is useful for or ameliorates acute suicidal ideation. So from my perspective, I think that this is true, or at least the study supports this claim. The study very clearly showed that even within 2 hours of starting treatment, suicidal ideation, as measured from the Beck scale for suicidal ideation, was in remission for over 40% of patients in the ketamine arm compared to less than 10% of patients in the placebo arm. The Beck scale for suicidal ideation is a very reliable metric. It's been used in numerous other studies, and I didn't see any confounders that blurred interpretation of this data, but there are a couple comments that I think need to be made regarding this. So this is a good metric, and again, they were studying remission of suicidal ideation, which I think is appropriate for this study. But we have to really think about how suicidal ideation relates with suicide attempts and completed suicide. And one of the ways that I think about this is in regards to the concept of like benign suicidal ideation versus malignant suicidal ideation. So a lot of patients that actually have suicidal ideation will never go on to make an attempt. And the study actually talks about how estimates are globally about 2% of patients in the population each year will have suicidal ideation, and about 0.5% of those patients will have a plan. But the vast majority of those patients will not make an attempt. So, one thing we have to keep in mind here is even if you improve suicidal ideation, it doesn't mean that you're affecting suicide attempts at all. And that's something that I think we need to keep in mind here. So it's possible that we were improving suicidal ideation in this study, but that it ultimately was benign SI. This could be patients that have personality disorders, or they just kind of feel hopeless, or have a passive death wish, but they may not have actually had any true intent. Now, obviously, this is the difficulty in psychiatry, is we don't know who truly is at risk, who truly will attempt, but it's something to comment on because it does kind of blur the interpretation of the data as a whole, especially in context with a couple other findings. All the same, psychiatry is in desperate need for tools to treat acute suicidal ideation. We have very few tools that work in this acute frame, and many of the tools that we use have other drawbacks. So ketamine does show some promise in this front. I do think that there needs to be a lot more research, but it is something that's worth considering. Now, the second claim that made was that ketamine is rapid acting, and I don't think that there's really any contested nature for this claim. I think that this is simply true. One of the main metrics they used was to look at things 3 days post-treatment, but statistical significance was reached within 2 hours for populaces, and they have the data that if they wanted to run that, they could show that. When you compare this to something like lithium, clozapine, or antidepressants, this is a far more rapid-acting treatment. And since we do think in a lot of situations suicidal ideation is a very acute, concerning finding, it is reasonable to speculate whether or not using a more rapid-acting drug is worth it for trying to reduce suicide attempts and completed suicide. However, that's not to say there are not barriers here. These patients were hooked up to monitors, which is probably the safest way to do these infusions, and they were watched by anesthesia whenever they did the infusion. So there's a whole delay of getting patients in the hospital, getting consent, getting them hooked up, and doing these treatments. So it's still not as if you can just have someone walk into a psychiatric ward, hook them up, and then they feel better. So there are still some delays, and there are obviously a lot of concerns. But there is some promise for rapid-acting reduction in suicidal ideation. And given that patients come to us looking for help, I think there is something to be said about the therapeutic alliance for using a treatment like this for someone who is acutely suicidal. But this is one of the things that I think was very concerning about the study, and this is this concept about ketamine being safe in the short term. In this study, again, that is 6 weeks. My opinion on this is that this is inclusive, but I do suspect it's false for some populaces, and I think it warrants a lot more discussion and a lot more research. So, overall, this is a study arguing that ketamine is safe and effective for managing acutely suicidal patients. They are looking at suicidal ideation. However, obviously, the thing that we are really concerned about here is suicide attempts and completed suicide. In our field, completed suicide is a relatively rare phenomenon. However, it's arguably the worst outcome that we can have as psychiatrists, and it's certainly the thing I think we try to avoid the most. There is a reduction in suicidal ideation from ketamine treatment, but there is no statistical difference between treatment arms for suicide attempts. And holistically, there were 7 suicide attempts and 8 suicide attempts if you consider the completed suicide in the ketamine versus 8 in the placebo, meaning there's absolutely no difference in attempts. Again, whether or not there's enough events and enough power for the study to identify that difference is something that we could address, but at least doesn't speak well for reducing suicide attempts from ketamine. And I think that's something to keep in mind. There's also something to kind of ask about what happened with the suicide, and that's something I wanted to talk about a little bit. So, imagine that you are structuring a study and you are studying antidepressants before we knew as much about them, and you are expanding it to the general populace, and you're including patients that have bipolar disorder. So imagine you're doing the study and you're finding, okay, suicidal ideation after a week or 2 weeks on these SSRIs actually gets better. But of note, some patient just decided to complete suicide, and we don't really know why. We would obviously be very concerned, and we'd want to know more about that. And so in that instance, it could be someone that had an adverse reaction to the medication. Maybe they entered into a mixed state, and that caused them to have more impulsivity, more dysphoria, and they might have attempted. Even if you didn't capture that initially whenever they got the antidepressant in the hospital, that doesn't mean they didn't have a delayed response to that. And with ketamine, I really think that there can be a lot of delayed responses that people just are not aware of. So this is something I wanted to talk about. And, this is anecdotal data, but I think when it comes to ketamine, this is very important because this is a substance that we don't get as much exposure to. I've never seen a patient in professional setting and actual psychiatric practice that came in that was suffering from ketamine withdrawal or using it acutely. But, I've known a lot of people, especially before I started med school when I was working more in addiction, that have struggled with ketamine addiction. And so, one story stands out about one of my friends who was very horribly addicted to ketamine. And I asked him about, how he ended up getting in that situation. And so, he had a lot of experience with drugs. He had messed around with methamphetamine, with heroin, with benzos, pretty much everything known to man. And he said, with most drugs, there's a typical progression of using them. You shoot up heroin or you do a line of cocaine and you get some form of euphoria and high. Whenever you feel intoxicated, it kind of makes you not worry about other stuff in your life and it makes you feel like everything's right. But as high as you get, you have a equal and opposite crash. So you will come down, and that can be a very strong compulsion for redosing. And so he said that's one of the big reasons why people do get hooked. That's why they keep using. But if you have some intellectual distance and if you are relatively intelligent, you learn this pattern very quickly. And then, as long as you expect that crash, it can help you mitigate the dysphoria from it, help prevent you from redosing. And that's one of the reasons why for a long time he managed not to get into trouble and to be able to hide his substance use. But ketamine was ultimately the thing that got him into trouble. And I asked him about that. And what he said about it is that with ketamine, you do have this acute high with it, and you have a lot of a dissociation. And the way he described it is that you have freedom. Your emotions feel like they're a step removed from you, so you don't have to follow them. And then you feel pretty good, you feel euphoric, and then you do come down, but you don't really return to euthymia. And you have actually a couple days where you feel good, like everything's going fine in your life. And so what he noticed was that he would use the drug, he'd feel okay, things would be going good in his life, and then maybe a couple days, so a week later, he'd start having issues. He'd start getting angry, impulsive. One of the terms he used was that he had no distance between how he felt and what he thought. So he'd get very caught up in his emotions, and he said oftentimes he'd be impulsive and explode on people and blow up relationships. And the thing about it is that he didn't have insight into being angry. It's like he didn't realize what he was doing, almost as if he had some form of mania, though he has never been diagnosed with bipolar disorder. And he said that after time, he started to realize that that was actually from the ketamine, and that there was this kind of delayed withdrawal from the ketamine that made him end up making mistakes. And so the reason I bring this up is, I think about a study where they say, well, the patient didn't respond to ketamine, but they didn't seem more depressed or anything worse immediately after they got it. And so that's not related to this completed suicide. But I think about a patient that does ketamine, maybe they have so much ego strength or so much barriers put up, they don't respond to it, or they just don't respond to it because of their physiology. But that doesn't mean that a couple days later, they don't have this increased impulsivity, this psychic energy, this restlessness that causes them to take what might be a benign suicide attempt or a less well thought out one to being something very impulsive that ends up taking their life. And that's one of the things that I think is very concerning. And that's one of the reasons why I do think that we need to be cautious about using ketamine, because I think that there are patients that are susceptible to this that are at risk for actually killing themselves, and that they might not if we didn't treat it. So, maybe we improve suicidal ideation, but are we actually saving lives? And I'm not convinced that that's been proven. And I think that's something we really need to consider. That's not to say that that's not possible. I mean, suicide attempt can happen. This could be a coincidence. It could be, like they said, someone who didn't respond to the treatment, and maybe because they didn't respond to the treatment, but they had some side effects, they knew they got it, that could make them more hopeless. That could be why they attempted. Ultimately, we don't know. There does need to be more research on it, but I am not comfortable with their statement of saying ketamine is safe in the short term, because I don't think that's proven, and I think the data might actually suggest against that. Another thing that we kind of have to think about with this is a very cherry-picked population. I mean, they're not including patients that have psychotic disorders, which is not always obvious. They have very few substance users. One of the big concerns I have is if we were to give this to someone who had a more prominent substance use problem, is it going to make them immediately decide to start using ketamine? Another question, is it going to make them decide they want to relapse and put themselves at risk? And that's something we have to consider, and we don't really have the data on that. Granted, the study wasn't set up to prove that, so that's not necessarily their fault, but it is something we have to consider moving forward. All right. Then the next part that we're going to talk about is this idea that ketamine has persistent benefits even past the acute phase of managing suicidal ideation. So with regards to this, I think that this is actually inconclusive. I suspect that it is true for select populations, but I don't think it's true in general. This is one of the first studies to suggest that ketamine has lasting benefits. Every other study they've done, at least for these IV treatments, suggests that after 3 days, you really don't see any benefit. And there's a question about why did they find this difference? One is that this is a much larger study, so it is better powered. Again, the meta-analysis that was done before only had 60 patients total. But even given this, if you're looking at it holistically, the study did not reach statistical significance. Yes, there's a difference between the treatment group and the placebo, but we don't have the degree of rigor that we would like from this, at least from a data perspective. But what I do think is if they were to be more mindful of this, if they were trying to look at different populaces, say how the bipolar patients responded over 6 weeks compared to the people that were in the major depressive group, I suspect you would find a persistent benefit for certain subgroups. I also think that there's a possibility for people that have PTSD or personality disorders that there might be some persistent benefit from ketamine. And, they had the data to analyze this. And as we looked at, they actually did analyze this at 3 days, but they didn't analyze this at 6 weeks. My perspective on this is that they are trying to push the idea that ketamine should be given to everyone to try and treat suicidal ideation. And I just don't think that this is right. I don't think that that's what the data supports. I don't think that's what we will end up doing in the long term. I could be wrong. We do need more data to figure that out. But another possibility here is that maybe bipolar patients respond very quickly to the treatment, but that effect wanes. And so maybe by blurring the data, looking at it from a little bit more distance, it looked better. But I think that there is a little bit of an agenda. There's a little bit of a narrative that they're pushing here. And I think that they could have been a little bit more genuine regarding the data. All the same, though, it's some pretty interesting findings, especially when it comes to different diagnosis. So we can kind of move on and talk about that. So what they did find, and this is, I think, the most important finding from the study, is that comorbid mental disorders moderate the efficacy of ketamine treatment. There's little doubt from the study that patients with unipolar depression respond dramatically differently compared to patients with bipolar depression. One of the things to think about regarding this is that when it really comes down to it, I think bipolar patients are some of the people we are the most concerned about completing suicide. They have that impulsivity, they have more energy, they usually are pretty high functioning in certain settings, and bipolar depression can be extremely crippling. And that's one of the reasons why, if this is an effective and safe treatment for bipolar disorder, we should consider its place and how we can use this. Again, I think we need more data on this, but we do know that there seemed to be no evidence of mania or psychosis from giving it to patients that had bipolar depression. Again, there's also the subset of patients that carry this other diagnosis that may respond to ketamine. And I suspect if you structured a study here where you exclude patients with unipolar depression and try and tease out more of the personality disorders as well as the anxiety disorders, you might actually see much better data. You might not have anyone who has completed suicide, or you might have more people that do it. We don't know, but it is something that I think warrants more investigation. When you're looking at this from kind of like a grand view, what this says to me is that if we are going to use ketamine therapy, we should handle it similar to ECT. Patient selection is extremely important. If you are doing ECT and you are giving it to patients that have persistent dysthymia due to personality disorder, or giving it to patients that have substance use issues that are really just dysphoric because they're crashing from methamphetamine, you're not going to see the same results from ECT as if you give it to someone who has bipolar depression with catatonia. And I actually think that's another thing which the researchers should have commented on, is how did this affect catatonic symptoms? My suspicion is that actually ketamine could be protective from catatonia. And if you're treating patients with bipolar depression, they might actually have a benefit from preventing them from becoming catatonic compared to something like antipsychotic therapy. I still think obviously you'd want to use mood stabilizers, particularly lithium, Integratol, which are the most well-studied for catatonia, but it's still something that warrants investigation, especially in future studies, and particularly if you do a study that is looking uniquely at bipolar disorder for using ketamine therapy. And then just kind of one other comment I wanted to make is, if this data is reproducible, and it truly is the case that patients that have bipolar depression respond dramatically better to ketamine than people with unipolar depression, this asks if there might be room for something like a ketamine challenge. Imagine you have a patient, they come in with depression, you're not exactly sure if it's bipolar or unipolar, but you want to try and find out, and you want to try and improve suicidal ideation, and you're going to keep them in the hospital for observation. Giving them a ketamine challenge might help you know if they have bipolar depression. And it is possible that we could actually use ketamine kind of as a diagnostic tool for trying to delineate between bipolar and unipolar depression. This is just a thought that I had from reviewing the data. I think the data does support that this is something to consider. But again, we need more research on it, and it's not clear at this time. But just one thing I wanted to kind of touch on for people that don't know this. Until the government relaxes the COVID accommodations for controlled substances, you actually can get ketamine through the mail from a telepsych appointment. There's this website called MindBloom where you can literally go, you'd have an interview with a psychiatrist over Zoom, and then after that, they can basically ship ketamine to your house in these little tablets, and you can do the treatments while they are watching you. So that means that you literally can have patients right now get ketamine through the mail with almost no oversight. If you are concerned about safety, which I think is something we should still be concerned about, this speaks to me of having some very dangerous potential. But there are longitudinal studies. I think one was actually published last year for televised ketamine therapy. The data is supposed to be pretty good on that. It's something that I think is worth looking into in the future. But there's also a question of what are we going to do as a society whenever these accommodations from COVID end. If I think we've actually talked about this before, but if the government decides to make all of these controlled substances require an in-person appointment, that means stuff like this is going to get shut down. In my opinion, that's probably safer. It might be good, it might be bad, we don't really know. But it's also interesting because we have the data that we'd be able to analyze outcomes for these televised appointments and compare it in the future to like someone being inpatient. So it's something I think that's worth thinking about, and I think it is very interesting. And I also found it particularly interesting because I don't think a lot of people know that this stuff is already being pushed for people. And there are also companies that are developing unique ways to administer ketamine. We already know about like ketamine, the intranasal treatments. This is a sublingual treatment, but there's a company developing a wafer that actually increases the potency of sublingual ketamine. Ketamine has about 30% bioavailability when you put it under the tongue. And the idea is to try and increase its bioavailability so that sublingual treatments are more effective. And then, of course, really, it's so they can have a patent so they can keep pushing it. But it's something to keep in mind because this is something that the pharmaceutical company is gung-ho on. They're pushing it, they're trying to make money, and they're going to do that. So either we try and see if they need reined in or not, or else they're going to just kind of run the show. And so I think that does speak about us needing to try and decide whether or not we're going to use ketamine in a more expanded setting. All right. So really that covers the presentation. So we can kind of open up the panel for any questions, any comments, any concerns that people have. All right.
Feel free to put questions in the question and answer. I'm promoting some people to panelists for discussion.
Hi, Nick. This is Dr. Huang. Yeah, very nice talk. And I share some of your concerns, like, whether it's truly double blind, whether the patient can tell, they were taking ketamine versus taking placebo. And can you hear me?
Yes, I can hear you.
All right. So the question is, how do we define, what is treatment? How do we determine, this thing is a treatment?
Well, I mean, I think one of the things we have to ask at is really what we're trying to accomplish. People use ketamine for different purposes. And if you're trying to really improve suicidal ideation and suicide attempts, we have to really look at that. And, using a metric to assess suicidality is still controversial, even if it's a good one. But I don't think that we've really clearly defined what treatment is and who should have those.
Yeah, is it because it's a treatment because it's a treatment because the doctor says so? Sort of like how do we define this is a treatment?
No, I mean, honestly, it's hard to say. And one of the thoughts I had, and I tried to find data on it, but if you did the same studies with giving people opiates, what would be the results? I mean, I suspect if you're suicidal and you get high on an opiate, that probably would improve it.
That's a good thought. That's a good thought.
And so that's something we have to ask.
But yeah, so that's one of my questions, yeah. But another thing is like I think so there is this lady, her name is Hu Hailan, and then she did some animal models on ketamine. It's pretty interesting. So they believe, basically they can create an animal model of depression by loss of social status. So you have a group of mice, say number 1 through number 4, and then you put them in the tube, head to head, have two mice, two mouse push against each other. And then so usually, basically number 1 always beat number 2, beat number 3, beat number 4. But if you manipulate it, you put a plug, behind the weak mice, or you push it, and then the weak mice actually can push out the stronger mice. So if you keep doing that to the stronger mice, because stronger mice, used to be winning all the time,
Interesting.
But if you mess with them this way, the stronger mice they lost their social status, they actually act like they're depressed. And then if you give them ketamine, they're winning again.
That is interesting. I haven't read about
look her up. Her name is Hu Hailan, HU. If you look for HU and then plus ketamine, you'll see her study. So I thought that's some sort of a very elegant study they done with the animal model. And then they speculated that this nucleus is called lateral corbenular. And then they call that, it's called anti-reward center. So basically, When it fires too much, you don't care about reward, you become depressed. And then ketamine actually suppress. I guess if I understand correctly, ketamine actually suppress that nucleus. That's how I treat depression. So it's like sort of like in the old days, bloodletting, leeching, was defined as treatment. And then so who decide like psychodynamic therapy is treatment, that kind of thing. Is it because historically we've been doing that, so that's a treatment, or we actually figure out the mechanism, and then we say it's a treatment?
Well, what I will say, one comment on that is I do think at this stage, one of the big players that's deciding this as treatment is the pharmaceutical company. I was talking with my therapy advisor, and she said that she had actually got emails from them asking to be part of this like Mind Bloom organization. So they design a drug, and they then reach out to find physicians that will help prescribe it and push it for them, when I think most of us are still trying to figure out how the data looks. I mean, this is a very well done study, but it just recently was published. And the fact that there's already stuff on the market, it does suggest that one of the big agencies deciding the treatment is the drug companies. But I think that what you said about psychodynamic therapy, whether or not it helps or not, is also something to talk about with ketamine. Most of the patients had no side effects for this, and people have talked about doing psycholytic therapy, where you give patients a drug and then you do psychotherapy while they're on that. If that's something that's going to happen, ketamine is something we should consider for that. I don't know whether or not it would help. My suspicion is that it actually might. But again, this is something we have to decide, and we need more data. And then over time, hopefully the perspective will get clearer.
Good. All right. Thank you.
Mm-hmm.
Megan has a comment in the Q&A.
See, I'll pull that up.
Basically, I just wanted to say that I thought the presentation was like really thoughtful, and I love how you included an interview with somebody that had taken ketamine before. I thought that was just really interesting to get that perspective.
That's actually something I wanted to comment on that I forgot. So, for some reason, and I don't really understand how it happened, there were 3 individuals in my high school that got pretty bad on the drug. And so, when you have chronic use, this is not something to kind of overlook. The worst cases I've seen, one individual, he did the drug so regularly, he became, for lack of a better word, permanently dissociated. And he decided, because he was so ambivalent to everything, to catch stray cats and started slaughtering them and doing anatomy, like dissections on them. And I've never heard of that happening from other substances before. Other reactions, one person, he was shooting up ketamine to the point of getting into K-holes and seizing, and he crashed 3 cars and really ruined his life. So there is that addiction to be mindful of. And I think that's something we don't see as much here. And that's one of the reasons I wanted to mention that. So thank you, Megan.
Hey, Nick, I enjoyed the presentation very much. I like the comment that you said about patient selection and to treat this kind of an ECT way. Definitely the data is scarce about that. Did you find anything in this article or when you were researching about the benefits of infusions versus the intranasal one, the esketamine?
Right. So what we did find is that the response is much more rapid whenever they do infusions. Also, one of the thoughts is that for when you're researching the study, it's easier to blind it because there's far less side effects from a slow infusion. And I think that's one of the reasons it's good for doing research. But there's also this kind of element where I think it's interesting because at the end of the day, having a pre-prepared bag to infuse isn't hard. This is something you could do at many sites. And as we already know that they are doing these infusions with nurse practitioners with very little supervision in the community. I think the Serenity Clinic and the Revive Clinic both do this. If this were helpful even the infusion isn't very difficult. But there is a lot more research that needs to be done regarding different forms. And then the sublingual forms and the wafers are really what a lot of the drug companies seem to be pushing, because it's easier to develop and patent that than make a whole intranasal administration device. And some people are very cautious about using that. But no, I think it's something that needs more research, and it's a good question.
Yeah, first of all, a good presentation. The landscape for ketamine has actually changed quite a bit recently, because I think it was sometime last year, the FDA came out with a statement, because a lot of people were actually reconstituting racemic ketamine in intranasal formulations and giving it to patients to take home. And so since then, actually, most of the compounding pharmacies have stopped carrying ketamine. And so it's actually a lot harder to get it now than it was back in the day. So I suspect that the questionable use of ketamine is probably going to decline over a period of time and kind of peter out for the most part. I think you're absolutely right. The issues around safety exist, but they exist for Suboxone, they exist for any opiates, they exist for muscle relaxers, they exist for benzos, they exist for literally everything. And so I don't think that we as a field are not equipped to handle those issues, because we've been handling them since time immemorial, really. I don't think we as a medical profession are not equipped to handle it, because I think we are, because again, we've been managing those and handling those since time immemorial. The economization of ketamine and the economization of healthcare and the creation of a two-tiered health system is, I think, more worrisome. Because not everyone goes into medicine for the right reasons. There's not a fine line between making a good living and providing quality care. That line is actually quite broad. It's quite visible, and you can tell when someone crosses that line over. And so you're able to do both. You actually are able to make a good living and provide quality care. And I think that's where we as physicians need to be more aware of. I think it's an excellent tool. I don't think that we need to necessarily understand the mechanism of action to deliver care, because if that were the case, then we wouldn't have treatments whatsoever. And neither would a lot of other folks, honestly. Like a lot of other specialties, they don't really fully understand the mechanism of action, but they still use the things that they use. For example, microvascular decompression. No one knows why Teflon works better than other things to stop trigeminal neuralgia over the trigeminal nerve. It just does. You don't need to understand why. But I think it's an effective treatment modality. And I'm going to use this as a plug, because we're probably within the next couple of weeks, we're going to start doing ketamine in our clinic. So that's going to be supervised by myself and Dr. Schroed. And so that's going to be probably the only physicians that will be that will have a medical practice providing ketamine in this community.
And one thing I think about it that I might not have hit on that much, but there was no manic conversion from these ketamine therapies. That is something I think we sometimes forget with ECT. I had a patient last month that, we weren't really thinking they were bipolar. It was a thought, and they became floridly manic from ECT. And if it's truly the case that ketamine doesn't carry that risk, that is a reason that it might actually be safer in some regards. But we just need more data on it. But I think that's very interesting. I'm glad you all are doing that. Are you going to do infusions, or how do you intend to kind of address it?
Well, no, we're going to do infusions. I think it's ketamine, for the analogy that Randy uses, kind of interesting, is that you kind of shake up the snow globe, and that's essentially what ketamine is for the most part doing, especially regarding brain circuits, et cetera. Which TMS is kind of nice, because TMS allows for the snowflakes to fall the way they should. Mm-hmm. And so that's the analogy that we use with our patients to kind of describe how ketamine could be complementary to or add to TMS in some capacity.
Okay, cool, interesting. Thank you.
Well, Nick, thank you for picking such a great topic. A good journal and a great topic. It's so important to keep psychiatry medicalized and to have this as another thing that people can do.
Thank you.
Yes, Nick, can you hear me?
Yes, I can hear you, Dr. Vincent.
So thank you again for a really interesting talk on ketamine. And I'm wondering how we feel about patients who come to us and ask for specific treatments. Oftentimes getting this straight off social media and different kind of forums that they're following. I think what we really should be hearing from our patients is their desperation to find something to make them feel better, whether it's their addiction to substances or it's their chronic suicidal ideation. I have an individual who's currently getting this IV ketamine, and that's after chasing multiple treatments for something that has not been resolved, including a stellate ganglion injection to address the anxiety. So I think too, we have to not say no right away, but we have to hear what they're really asking us for, which is some treatment that helps. And ketamine may be it.
And that's actually something I think that's really important here, because patients come to us for help. And we all have struggled in the past with establishing rapport with patients, especially whenever they're handled acutely or against their will. And if we have a tool that can at least make them feel better, make them not want to die, make them think that they're improving, even if that doesn't clinically translate to anything more than that, it can be used as a bridge to help get people to take medicines that we are very confident help them. I do think there is actual therapeutic utility to ketamine. I think that we're going to eventually find that out with more data. But I think that this is actually a promising thing to consider for like managing first breaks, especially if you think they're bipolar and they're so suicidal and mad about being in the hospital. If you do this treatment, they feel a little better. Maybe they start taking a mood stabilizer. Maybe they get better quicker and their prognosis is better. So it's something to think about. But you're absolutely right. We need to listen to the patient. We need to hear what they're saying, and we need to let them know that they're heard and try and help them.
Thank you.
Thank you, Ryan. The increase in the improvement in quality of life is does have clinical utility. That is a clinical outcome, in my opinion. You know, and I think you hit the nail on the head when you said that patients, this might be kind of a step in the right direction. I mean, yeah, there's a lot of folks that we actually treat with. There's a lot of folks that actually are not motivated to even seek out TMS or therapy, et cetera, unless they get better to a certain level. And that's I found that to be very true in at least in our practice here, that folks need a little bit of boost. They need a little bit of improvement so that they can kind of go the full distance.
All right, thank you. I think that's actually very insightful. Ariel, do you have a question?
Yeah, I did. I think along the same vein, you had mentioned Mind Bloom, and I've seen advertisements, I'm sure we all have on social media about it, but and companies like that where patients can secure their own psychedelics and essentially do self-guided, like psychedelic assisted help. What do you think about that? How would you talk to a patient about their own personal use of psychedelics, and what do you think the market is for that kind of self-treatment as access to psychedelics therapeutically is increasing?
Right. So what I will say as an overview is that I already know that lots of people in the community, lots of patients are going to be able to get hallucinogenic drugs, whether it is through legal means or non-legal means. And my perspective on it is that this is pretty much going to happen. And we should be the people to try and help tailor these to be used appropriately and help give them guidance, help them know when it's safe, help be able to catch them if something bad happens. We don't necessarily have to endorse it. I mean, there are lots of questionable things that are done. And I think there's going to be more of that in the future. But one thing I will say that I think is worth considering is that even if we don't allow classical hallucinogenics or psychoactive drugs like MDMA and ketamine and psilocybin to be used, there are already companies developing analogs that are not going to apply to these laws, and they're going to push them. For example, I believe it is called S-methadone, is a medication that's somewhat similar to ketamine, even though it is an analog of methadone, that Dr. Install is researching to use for psycholytic therapy. Now, maybe we don't allow people to use ketamine, but this is likely going to eventually enter the market if the studies go well. So this is going to enter the market regardless. And the question is, do we use the time we have now to try and use these tools, help guide patients, or do we create a system where it becomes antithetical? One of the worst things we can do is to say, oh, if you take psilocybin to help yourself or ketamine, then you're breaking the law. This is bad. And then we start publishing our own drugs that the pharmaceutical companies have patented and they can make money on. It will make people hate us as a field. And that's something that we definitely have to be mindful of. At the same end, we don't have to endorse it. If we think it's dangerous, we should make an opinionated and consistent stand against it. But there's a lot of nuance to it. And my perspective is that we should have some form of stake in the game and try and make sure we guide people. So I don't know if that answers it, but that's some thoughts on the matter.
Yeah, thank you so much. I really appreciate your perspective. Really great topic and presentation.
All right. Does anyone else have any questions? Anything you all want to talk about?
Thank you, Dr. Bonomo.
Maybe this
Thank you
isn't
so much.
maybe this isn't too widely interesting, but my daughter was a resident about 10 or 15 years ago, and she was in on some of the early emergency room applications of acute suicidal ideation with ketamine. It's just been so ketamine has sort of been on my radar screen for a couple of decades. It's been pretty interesting. Thank you for doing this. You look great, and your editorial comments are perfect.
Thank you. And, that's actually something for us to remember too. The ER here at U of L has been giving ketamine for numerous things for a long time. There was one day I worked in the ER here during residency where just for kind of learning purposes, every patient got ketamine for pain control. And these are huge doses that are given instantly. It's not even close to the tolerability of these infusions. So, other people are using these drugs much more recklessly. So it's something for us to consider whenever we're thinking about whether or not we want to try them, because there haven't been a horrible number of horrible outcomes from that. So it's something to keep in mind whether or not that is something we want to consider. Granted, our patients are sicker, there's more risk, but it's important to keep in mind. All right.
Thank you so much, Nick. We really, let me see. We have another question that popped up. Ali had a question too. He says, I was wondering,
the metabolism studies. So those have been a lot smaller in size. And what they have found is that there is more consistent comparison between people that experience any side effect. And the way I interpret this study is that they felt like it would be useful in the future to try and use midazolam instead. But there isn't a good enough data to really know if there's difference. I will say that my suspicion is that there won't be, but it's really a good point to make, because I had made the comment earlier about what if you were to give people opiates to try and improve SI? Well, some patients do get better just from giving them benzodiazepines. Now, Versed, quick on, quick off, but there's a question of would that help them some? So I don't really know what's the best placebo to use. My suspicion is that you might actually want to use something like Benadryl or something that's a little bit more of a deliriant. But Versed safe, it's well known, and it does cause some degree of dissociation derealization. So it's something we need to look into, and I'd be curious to see what people use in the future. So thank you, good question.
Well, thank you, Dr. Bonomo, and thank you everybody for being here.
Well, I think with that, we can wrap up, and I appreciate you all listening to this talk, and hopefully it has given you some stuff to think about, and I'm very curious to see where things go in the future with regard to ketamine and similar medications.
We're excited to see it too. Thank you so much. Great job.
Thank you.